Hi friends, today's our topic is Gestational Trophoblastic Disease. In this video, I am going to discuss about different types of Gestational Trophoblastic Diseases, its clinical manifestation, treatment modalities, follow-up and prognosis. So without wasting time, we'll move on to our today's topic. We'll start with an introduction. Gestational Trophoblastic Disease, which include hydatidiform mole, invasive mole, placental site tumour, choriocarcinoma. Normally, trophoblastic tissue, it's a part of blastocyst. It inverts the endometrium to form placenta. Gestational trophoblastic disease proliferate abnormally and aggressively. Let's discuss about hydatidiform mole in detail. It's a benign tumor of trophoblast. There are partial or complete mole. We'll discuss about the partial mole, which is more common than the complete mole. Fetal tissue is present here. Cells are triploid derived from 2 sperm and 1 egg. Usually it is rarely become malignant stage. When we discuss about the complete mole, which is less common, here there is no fetal tissue present. Cells are entirely paternal in origin. Sperms fertilizes an empty egg which undergo mitosis. Cells are diploid in numbers, that is 46XX. Here the 10% risk of malignant changes. Let's see about invasive mole. It's a tumor-like process invading the myometrium. It has metastatic potential. It follows a complete mole. It may resolve spontaneously, also which is less aggressive than a true cancer. Next we'll see about choriocarcinoma. It's a carcinoma arising from trophoblast. It usually occurs after a mole or miscarriage, even after a normal pregnancy. Here we discuss about the clinical features of gestational trophoblastic disease. The symptoms include bleeding in early pregnancy. Symptoms of pregnancy are exaggerated. Also here there will be an excessive hyperemesis and vomiting. Early onset of preeclampsia or hyperthyroidism will be present in this case. In abdominal examination, uterus is larger for date. The investigations include ultrasonography, which shows a snowstorm appearance, which include hydropic grape-like vesicle within the uterus cavity. The serum beta-HCG will be grossly elevated and chest X-ray has to be done in order to exclude the metastasis. This is the snowstorm appearance which we can see inside the uterus when we do ultrasonography. It is especially seen in case of hydatidiform mole or molar pregnancy. Let's discuss about the management aspect of gestational trophoblastic disease. The main management is suction and curettage. It should be done along with oxytocin infusion. A trained staff has to perform the suction and curettage in order to avoid incomplete evacuation or perforation. Histopathological analysis of tissue should be sent after curettage. Anti-D immunoglobulin also has to be administered in case of negative blood group. Hysterectomy can be performed if the woman is completed their family. Let's discuss about the follow-up after suction and evacuation. Serum beta-HCG sample should be obtained at a second weekly interval post-evacuation until normal level are reached. The urine beta-HCG samples are requested at a 4-weekly interval until 1 year of post-evacuation, then every 3 months in the second year of follow-up. If the patient beta-HCG value reaches normal range within 8 weeks of evacuation, she should be under the follow-up of 6 months. New pregnancy at the end of that 6 months period will be permitted. Patients who do not have normal beta-HCG value within 8 weeks of evacuation should be under the follow-up of 2 years. Pregnancy will be advisable only after beta-HCG level has been normal for 6 months. Lastly, we reach the prognosis of gestational trophoblastic disease. Malignancy will be suspected under the following condition: persistent vaginal bleeding, persistently elevated or rising beta-HCG, evidence of metastatic spread to the lungs. Tumours is highly malignant but also very chemosensitive, so she has to take proper treatment. Here we can wind up our today's section. I hope you all understood about the gestational trophoblastic disease and its management. So in the next class, we will meet with another episode of midwifery topic. Till that, take care. Bye-bye.